Changes are happening here at the ACR. Our new website is live, and along with it is a new membership model, redesigned with simplicity in mind. Streamlined with meaningful benefits for your career journey. Our new membership model is not only for you individually, but also for your team of 4, 6, or even 15 rheumatology professionals. Learn more at rheumatology.org. ACR and ARP, where membership means excellence. Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, Google Podcast, and on your favorite podcast app. Like many rheumatic diseases, sarcoidosis can affect almost every organ in the body. Its complexity, however, can also make it very challenging to treat, especially when multiple organ systems are involved that require expertise from various specialists. Oh, if only there could be one doctor that specializes in the care of patients with sarcoidosis. Oh, wait, but there is. My guest today is Dr. Adam Morgenthau, a genuine sarcoidologist. Our discussion today will span the entire life cycle of the disease, starting with what it is, why it occurs, and potential environmental triggers for sarcoidosis. We'll shed light into making the diagnosis of sarcoidosis and the need for imaging or biopsy. We'll distinguish between organ involvement and organ damage and discuss when to treat, including the various medications that can be effective for various organ system manifestations. At the same time, Dr. Morgenthau dispels many myths that rheumatologists have about sarcoidosis. For instance, that patients with sarcoid have disease flares, or that if it doesn't respond to prednisone, you should use stronger drugs. We finished the episode discussing the latest research into sarcoidosis and the work that he's done to provide support for patients living with sarcoidosis and their families. Dr. Morgenthau is the director of the sarcoidosis program at the Icahn School of Medicine at Mount Sinai, my alma mater. He trained as a pulmonologist, but he now exclusively sees patients with sarcoidosis. He directs Mount Sinai's sarcoidosis clinic and trains pulmonary fellows in this specialty. He also directs Mount Sinai's sarcoidosis support group and has done a ton of research and been involved with national guidelines about sarcoidosis. I really think this episode should be required listening for anyone that manages patients with sarcoidosis. Enjoy. Adam, welcome to the show.
Thanks for having me, John. I appreciate it.
Adam, you call yourself a sarcoidologist. What the heck is that?
Yeah, I think it's a term that a few of us who do this for a living came up with. I don't know if it was spontaneously, but just after having done this for many years, I think it really involves sort of taking care of patients with sarcoidosis exclusively, but not patients who may have one simple organ manifestation, patients who are complex, of multi-organ disease. And, your role is really to manage them holistically and systemically, and sometimes obviate the need for, a million referrals to subspecialists. And it really, I'm biased, but it really is an art, I think. And it does require some expertise to be looking at multiple organ systems at once. We're so used to as specialists to be focused on one particular area that we may neglect others. So I do think it's a skill that people acquire over the years.
You know, you sound like a rheumatologist. I mean, I think we're the ones that are trained looking at, all these various organ systems. And, I'm so happy for you to hear that you're doing the same thing.
Yeah, I think it's similar in a lot of ways. And, I think if I didn't become a pulmonologist, I probably would have become a rheumatologist, honestly, because I sort of think that way. Although I will say that, I did think briefly about being a nephrologist because I've always told people it's the paired organs that count.
I love it. So, Adam, how did you become interested in sarcoid? I mean, to become a sarcoidologist, you have to have developed that interest somehow in the course of your career. How did it happen for you?
Yeah, I don't think it was one like impactful event. I think it was kind of a series of a couple of different events. You sort of go through medical school and you go through residency, as you do a residency in internal medicine, and you start to understand what your strengths are and what your weaknesses are. And, obviously, I sort of knew early on that there were aspects of pulmonary disease that I liked. And I felt that I was better at than other things. I was a terrible endocrinologist. But I think also early on, even in medical school, I was fascinated with the fact that we have internet, we've gone to space, we've got cars that go 0 to 60 in under 3 seconds, and we had a disease that was discovered in the late 1800s, and we still didn't know the cause. And I felt like somebody has to figure out what's causing this disease. Now, I didn't necessarily think that I was going to be the one to do that, especially when I knew that I was probably going to be more of a clinician than a basic scientist. But that was an important part of it. And also, the other part of it is I really do like the systemic nature of sarcoidosis, the fact that you have to think about multiple organs at the same time, multiple organ involvement, how one system may affect another system. It's sort of it's satisfying to be able to sort of care for the patient holistically.
Yeah, again, you sound like a rheumatologist. With all of our diseases, we have no idea what causes them. I think that's also part of the reason why I became interested in rheumatology is the fact that we have, rheumatoid arthritis and lupus and systemic sclerosis, and we still have no idea, you know, what's for a lot of them, what's driving it. So let's delve into sarcoid a little bit. What is it? When people ask you to describe what sarcoidosis is, what do you tell them?
Yeah, what I generally say is I start off by saying it's an inflammatory disease. And then I say it's a disease of uncertain etiology rather than unknown, because
Aha.
I think that, in the last 10 to 15 years, we've learned a lot about the pathogenesis, but not enough where we're able to say this is the cause. And because this is the cause, we can eradicate it and move on from there. So I say it's a systemic disease. It usually affects more than one organ. It's inflammatory. It's uncertain etiology, and really, it's sort of characterized by, an exposure to either probably a bunch of unknown antigens. And for genetic reasons, people have a predisposition to have an immune system that doesn't manage those antigens very well. And in doing so, the immune system sort of goes into overdrive and it forms these, microscopic collections of immune cells called granulomas. And in sarcoid, that happens to be, very granulomas in a very specific conformation known as non necrotizing granulomas. And the interesting thing about sarcoid is that sometimes these granulomas, we see them in organs on imaging tests and other testing that we do, and they're just in the organ. They sit there. They don't cause any problems, no symptoms, no pathology, nothing. And then in other people, for reasons that we don't completely understand, these granulomas get turned on, they create inflammation, and then it's the inflammation from these granulomas that disrupts the normal function of organs. And that's really what leads to symptomatology. And inevitably, if you have this ongoing chronic inflammatory process that's untreated, that can result in scarring. And when you get scarring in any organ, you have a tendency to develop irreversible damage. So that's what I would say it really is in a nutshell.
So I think when I was at Sinai and I was learning about sarcoid, over a decade ago, I did learn that it was of unknown etiology. Tell me more about some of the findings over the last 10 years. You mentioned that there's a suspicion that it may be related to certain antigens. What could those antigens be? Where are they found and how did they get into the body?
Yeah, there's not a simple answer to that question. What I would say is, first of all, we know that based on a really important study that was conducted in the 1990s among roughly 12 centers in the United States called the ACCESS study. And the ACCESS study is an acronym for a case controlled etiology study of sarcoidosis.
Hmm.
And the study consisted of about 700 patients with matched controls by sex, age, race. And really, what the study sort of asked was two primary questions. One, is sarcoidosis associated with, are the clinical manifestations of sarcoidosis associated with age, gender, and race? And is there one predominant environmental or occupational exposure associated with sarcoidosis risk? And after doing this study over a number of years, I think it was 3 or 4 years, what they found is to question one, sarcoidosis clinical manifestations are associated with age, gender, and race. But more importantly, and to the surprise of all the investigators participating in the study, is that there was not one particular predominant etiologic exposure associated with sarcoidosis risk. And what they found was is there were multiple exposures, 4 or 5, that were associated with sarcoidosis risk, but very, very modestly. I'm not a statistician and I don't know statistics all that well, but I can tell you it was odds ratios less than 2. And we
Hmm.
all know that odds ratios less than 2 are really, really mild associations. And those associations occurred with people who were exposed to pesticides, insecticides, moldy environments, musty odors in the workplace. All of these odds ratios were in the 1.5 ish range. So that was a hint that there was an environmental occupational exposure associated with risk. But after that, people have done studies actually looking for antigens, foreign proteins that are associated with sarcoidosis risk. And one group at Hopkins showed in the early 2000s that there's a remnant protein of mycobacteria called mycobacterial catalase peroxidase G. And this was shown to elicit more immune responses, antibody immune responses in patients with sarcoidosis with respect to controls. And at the same time, more recently, Andrew Fontenot at University of Denver has shown that there is a higher reactivity, antibody reactivity in sarcoidosis patients compared to controls with respect to an antigen called Aspergillus nigelans. So there are all sort of these environmental things that are creeping up. And to sort of put icing on the cake, we know that people who were exposed at World Trade Center have a much higher incidence of sarcoidosis compared to people who were not exposed.
Hmm.
So the incidence of sarcoidosis in general is somewhere in the US is somewhere around 8 per 100,000 per year. But in patients who were exposed at World Trade, it's somewhere between 20 and 30,000 per
Wow.
100,000 per year.
Wow.
So there was something in that gook that everybody inhaled that is antigenic. And then presumably the people who developed sarcoidosis also had a genetic predisposition to develop sarcoidosis as well. And it's those things predominantly that influence sarcoidosis risk. There are some other things, but those are the two most predominant things.
Fascinating. So it seems like in people that are sort of genetically predisposed and they have this environmental trigger, whether it's a bacterium, a fungus, or some other toxin, they have this sort of inflammatory reaction that causes the granulomas in various organs. That's fascinating. Um, Tell me what organs are typically affected. Everybody thinks sarcoid is a disease of the lungs. Is that the case for most people? And what other organs can it affect?
Yeah, access study and subsequent studies showed that, about 90, if not 95% of patients with sarcoidosis have lung involvement. But I think one of the important things that I always stress to patients and other doctors who aren't familiar with sarcoidosis is that involvement does not necessarily uh, denote activity and is not the same as true disease.
Hmm.
So patients can have involvement of their disease but not manifest symptoms and not have organ dysfunction, which actually causes symptoms. So patients, 90% of patients, if you do an imaging test, you're going to see evidence of sarcoidosis in the lungs, but that doesn't mean that they have overt pulmonary dysfunction or even pulmonary symptoms. But just about any organ can be involved in sarcoidosis. There are some that's almost never involved, like the pancreas, the thyroid, prostate, things like that. But 10 to 15% of patients have cardiac involvement. Roughly 20% have skin involvement. Patients can have lymph node involvement. Patients can have involvement of their kidneys, their liver, their spleen. I can go on and on. Eyes, brain, really any organ for the most part.
Interesting. So you're sort of making a difference between involvement, meaning that you may be able to find granulomas in certain organs, but not necessarily disease, so that you may have granulomas in your liver, but perhaps not have liver damage related to that, and so forth. That's interesting. So how do people get diagnosed with sarcoid?
Yeah, so sometimes it's pretty straightforward, and sometimes it's not straightforward at all. And in fact, there have been a number of papers that suggest that there is a delay in diagnosis of sarcoidosis because, it's often not recognized by people who don't have their antenna up for the disease. That being said, there are a handful of patients who get diagnosed incidentally, and it's not uncommon for patients to go to the emergency room because they were just in a motor vehicle accident and they have a chest x-ray and the chest x-ray shows bilateral hilar adenopathy, and all of a sudden the doctor comes into the patient and says, you have lymphoma, you better prepare, but before you prepare your life you should just get a biopsy to be sure. And patient goes to get a biopsy and they find out they have sarcoidosis, and that's why we used to hand out these pamphlets saying the good news is you have sarcoidosis. Anyway, so many people are diagnosed incidentally, but other people are diagnosed when they're symptomatic. And patients can be symptomatic from a pulmonary point of view, in which, usually the onset of symptoms is a bit more subacute to chronic. But patients can have, an acute arrhythmia. And that can be the manifestation of cardiac sarcoid, or patients can suddenly have manifestations of hypercalcemia,
Hmm.
and that can be the manifestation of sarcoidosis. Sudden neurologic deficits can be the manifestation of sarcoidosis. So, it's really a disease that keeps you on your toes as a practitioner.
Fascinating. So when you see a patient that you think may have sarcoidosis because perhaps they have pulmonary findings, or perhaps they did a biopsy that showed this non-caseating granuloma, how do you think about evaluating those patients and trying to figure out, what organs are involved? Do you do additional imaging, additional biopsies, or what sort of studies do you think about doing?
Yeah, so I would say there's some standardization to this process, but then there are sort of, for lack of a better word, artistic differences in how people approach this. There's some people who automatically, when they suspect somebody has sarcoidosis, they like to do a PET scan.
Hmm.
And, the PET scan is quote unquote meant for staging purposes, which is a word I don't like in sarcoidosis. And maybe if we have time, we can discuss later on. But anyway, they do a PET scan and they see that there are lymph nodes that light up, there are nodules in the lungs, and the spleen is large, and that may be a way to sort of sort out which organs are being affected. But typically that's not something that I do, because I think that, to sound like I'm dating myself and I'm old school, there are sort of other testing that you can do that doesn't involve radiation and isn't quite as confusing as the PET scan in many instances, which allow you to sort of screen other organ systems.
Hmm.
So for the lungs, obviously, you would start with a chest X-ray, but you can always, do a CAT scan, and should do pulmonary function testing. For the heart, an EKG is essential. For the eyes, every patient with sarcoidosis should see the ophthalmologist at least once a year. So we screen that way. With respect to the liver and the kidneys, it's usually blood work. With
Mhm.
respect to the bone marrow, it's usually blood work. Skin is an observational finding on exam. We don't routinely screen for brain disease unless patients have symptoms. And there's a bit of controversy about how we should be screening each particular organ system. But I think suffice it to say, there are basic tests that can be done for individual organ systems, which allow us to get a sense of whether that organ is involved, and more importantly, whether that organ is dysfunctional.
Hmm.
Because it's really the dysfunction that is the primary indication for treatment.
Got it. So if you have somebody that has sort of lung findings with the hilar adenopathy, does do all of those patients require biopsies, or just the ones that you think have sarcoid? How do you figure that out?
Yeah, that's a great question. And the reason it's a great question is because um, it was recently addressed by the American Thoracic Society clinical practice guidelines, which
Mm.
were published in 2020. And I was fortunate to be part of that. And, there's always been this long-standing debate about whether if you have a patient with asymptomatic bilateral hilar adenopathy, let's say we go back to their discussion a few minutes ago, the patient who gets in the motor vehicle accident has a chest X-ray and shows bilateral hilar adenopathy. They have no symptoms. What should you do? Should you say that they have sarcoid? Should you biopsy them? Should you be concerned about lymphoma? Do you want to miss lymphoma? Obviously, you don't. So, how do you approach that? And I think there isn't a uniform answer, but the committee, after considering this question and reviewing the evidence, basically sort of took a cop out. But the cop out, I think, is a reasonable cop out in that they said this decision to biopsy should be made on a case by case basis. And there were a lot of factors that go into deciding whether somebody should be biopsied. Those range from, where is the patient being diagnosed? If they're being diagnosed in New York as opposed to, the Mississippi Valley, then, you don't have to consider histo as an alternative diagnosis
Uh-huh.
quite as often. So you may say, listen, I don't think this is histo in New York, so I'm comfortable. I also don't think this is lymphoma. I'm comfortable watching this patient. On the other hand, if you live in the Mississippi Valley and you're not sure if it's histo, you may want to know. Other factors come into play, such as does a patient have any other symptoms that would ring true of lymphoma? Because obviously that's the diagnosis that you don't want to miss.
Yep.
The procedures that we would do to diagnose somebody with bilateral hilar adenopathy is usually what's called an endobronchial ultrasound, or EBUS. And
Mm.
that's something that accompanies bronchoscopy. And that's gotten wide acceptance as a standard tool during the past, I don't know, 10 to 15 years. And it's actually a really important contribution to our field because EBUS is incredibly safe. And the diagnostic yield of EBUS in the proper clinical setting in the hands of an experienced operator is somewhere around 85%.
Mm.
So if you have a patient with bilateral hilar adenopathy and you decide that you want to do a bronchoscopy with EBUS to diagnose them, you have a very good chance of making the diagnosis, and you have a very good chance of not hurting them, causing any morbidity and mortality. And the other thing is that, the risk of bronchoscopy is quite low as it is, but the greatest risk actually comes from pneumothorax. And if you do an EBUS and you biopsy the mediastinal lymph nodes and you have a pathologist in the bronch suite looking at the specimen that you take in real time, that's called ROSE, rapid on site evaluation of lymph nodes, and you see granulomas, non necrotizing granulomas, then that obviates the need to do a lung biopsy. And if you obviate the need to do the lung biopsy, then you cut down on the risk even more. So if you have somebody at a center who's very experienced in doing EBUS, then that's a reason that favors biopsying somebody with asymptomatic, bilateral hilar adenopathy. I think the last thing that I would say matters when you make that decision is patient preference, of course.
Mm-hmm.
And, there's some patients who really don't want to undergo procedures at any cost unless, it really is going to tell them something that changes management. And there are other patients that feel really comfortable knowing, hey, I've got closure. I know this isn't lymphoma. and it is sarcoidosis, and I want to know that, and it's going to help me sleep at night. So I'm going to have this procedure. And there are arguments for and against in doing this biopsy. Of course, there's also the medical liability issue. And I think, nowadays we always tend to err on the side of being sure that we're not doing anything egregious. And, with all of these factors taken into account and the fact that EBUS is generally a really safe procedure, I tend to lean towards trying to biopsy my patients.
Got it. So EBUS, just so that I'm clear, is an endoscopic ultrasound, but the point is to get a biopsy of a lymph node using the ultrasound guidance. Is that
Correct.
how it works? Got
Correct.
it. Got it. So you ultrasound the lymph nodes because that's um, has less morbidity as compared to like biopsying a lung.
Correct. And we're actually visualizing the needle entering the lymph node in real time. Before EBUS, we used to look at the CAT scan and we used to say, okay, this lymph node is about 5 centimeters from the carina. So when I go in, I'm going to artificially look 5 centimeters from the carina and try and stab that lymph node.
Uh-huh.
Now we're actually seeing the needle go right into the lymph node in real time. And that has a lot of advantages in terms of morbidity and accuracy.
Super. So if you once you make the diagnosis of sarcoidosis in a patient, who should be part of the team? I mean, it sounds like, when they're in your hands, you are their sarcoidologist and you sort of take over a lot of their care. But, when they're in other areas, what team members do you think the patients with sarcoid should have on their team?
Yeah, I think there are multiple answers to this question. It's somewhat dependent on institution. There are some institutions where sarcoidosis is really considered a rheumatologic condition, and rheumatologists primarily care for the disease. And, rheumatologists are very good at sort of thinking systemically, like we were talking about before, considering multi organs, et cetera, et cetera. And it's in the hands of a rheumatologist, and sort of the pulmonary person is consulted just to make sure that the chest imaging and the PFTs are okay. But in other institutions, pulmonary is king, and we're the ones that are driving a lot of the management. But that doesn't mean that we don't need support from all of our multidisciplinary colleagues. And I think a lot of the tendency to refer depends on your comfort level with certain manifestations of disease, your experience in treating those manifestations of disease, the availability of these specialists at your own institution. We're fortunate enough to have really a great cadre of subspecialists in various fields who can really help out when we need it. That being said, I am a sarcoidologist and I do a lot of this stuff myself. I was trained to do a lot of this stuff myself. And if my job is to know my limitations, and when I know my limitations and I know that I can take care of something well and don't need expertise, then I try to relieve that burden on the patient. On the other hand, there are absolutely times when I really need help from my colleagues, and cardiac sarcoid is classic when we have a patient who comes in, they complain of chest pain and palpitations, their EKG is abnormal. The standard practice to diagnose cardiac sarcoid is a cardiac MRI with and without contrast. We do that, and we see late gadolinium enhancement indicative in a non-ischemic distribution, indicative of cardiac sarcoidosis. And the real importance of the electrophysiologist comes into play in this setting. And what I mean by that is we know that patients who have cardiac sarcoidosis and have late gadolinium enhancement on their cardiac MRI are at risk of ventricular arrhythmias. And when they have an ejection fraction that is below 40%, they're particularly at risk of ventricular arrhythmias. But what about patients who have a normal ejection fraction? Those are the ones that we're a little bit uncomfortable with, their risk for ventricular arrhythmias. And of course, sudden cardiac death occurs in about 30%, 25% of patients with cardiac sarcoid.
Wow.
And that's something that we don't want to miss. So when we have a patient with late gadolinium enhancement, an abnormal cardiac MRI, and a normal ejection fraction, we want to understand what the risks are. And there are various ways at getting at that. One way that we can get at that is risk stratification for ventricular arrhythmias, is to do what's called an electrophysiologic study. And an electrophysiologic study, I'm going to make it very simple because I'm not an electrophysiologist, is, we basically send the patient to the electrophysiologist who, in a very controlled setting, introduces electricity into the heart and watches to see if the electricity travels down the length of the heart and that patient is predisposed to develop ventricular arrhythmias. And if they are predisposed to ventricular arrhythmias, then it might be wise to observe them. And multiple studies on this subject have showed that the electrophysiologic study, when it's negative, it has a very high negative predictive value for the absence of ventricular arrhythmias within the next 2 to 3 years from the time of the test. We need our EP colleagues, all the time in this particular setting. We rely on our rheumatology colleagues too, of course, and that happens when we have patients with, really bad joint pain that we can't control. But a lot of times for me, when I refer to rheumatologists is when I'm really not sure whether the joint pain is sarcoid related or not. And I need somebody to say, no, this patient does not have comorbid rheumatoid arthritis, or this isn't just run-of-the-mill osteoarthritis. So I don't end up giving them a systemic anti-inflammatory therapy for a reason that they don't need.
Interesting. And you just mentioned working with rheumatologists. I'm wondering if you have, having seen hundreds of patients with sarcoid, are there common sort of misconceptions or mistakes that rheumatologists make in sort of the evaluation or treatment of patients with sarcoid?
I'll answer that question, but I want to just flip it on its head for a second, because there's something that I think the rheumatologists do really, really well that a lot of other practitioners don't do well. And that is, the rheumatologists really understand the concept of steroid sparing. And I'm not sure that many of my colleagues in the pulmonary field and other people understand fully. And that is this concept that, you're introducing these other drugs, these anti-inflammatory medications, to lower the dose of prednisone. And why are you doing that? Because the side effects are dependent on the dose. The smaller the dose of prednisone, the less side effects. And that's why we use these other medications. By and large, except for Remicade, these medications are not as effective as as prednisone in the treatment of sarcoidosis. So the approach, and this is how I was trained, and this is how I train our fellows, is that, if prednisone's not working, then it's not sarcoidosis, or it's something that is not responsive to prednisone because maybe the patient is scarred. The approach should not be, okay, I'm going to try methotrexate, or I'm going to try, azathioprine. The azathioprine and the methotrexate should be used when prednisone is working, and you actually want to get the dose down. Okay, so rheumatologists really get this, and they do this well. The thing that I think rheumatologists don't always get is that, they always use the term with respect to sarcoidosis as a flare, and the disease is flaring. And sarcoid disease, generally speaking, I mean, you may get a little bit of a different opinion from different practitioners, but most, I think, would agree with me that sarcoidosis really doesn't flare for the most part. It becomes active. And there's actually a difference between the two. Flaring denotes, sort of this worsening activity, worsening of symptoms over a period of days to weeks. Whereas activity is a more subacute process. It happens over weeks to months. And by and large, when sarcoid becomes active, it becomes active slowly. There are a few exceptions to this, right? A sudden cardiac arrhythmia, a sudden neurologic deficit. But even most of the time when you get sudden symptoms related to hypercalcemia, that calcium has been, slowly accumulating for a while. And it's not just that second that calcium becomes a problem. So I try and teach our fellows and educate other people who are interested. I try and say, listen, by and large, sarcoidosis doesn't flare. And that's why when a patient comes in with acute pulmonary complaint, almost never is it sarcoidosis that's causing that acute complaint. It's either a complication of sarcoidosis or it's something other than sarcoidosis.
Fascinating. I think that these are such great insights that I'll certainly try to remember from now on when I take care of my sarcoidosis patients. So, how do you think about treating patients with sarcoid? You made a distinction initially is that you have organ involvement, but it may not necessarily be causing any trouble. So, how do you decide whom to treat?
This has evolved over the years. I think initially when we first looked at sarcoidosis, the uniform um, consensus gathering indication for treatment was organ dysfunction. And I think that drives most of our decision making still to date, is that if the granulomas are in the organs, they're causing inflammation, and you have some sort of measure of organ dysfunction, the physiology is impaired, then that is an indication for treatment. And the reason is because we know from observational trials that chronic untreated inflammation has the tendency to develop into scar, and once scar sets in, it's irreversible and not treatable. Although we have some new drugs like antifibrotics that potentially could be used, but have not really been tested in sarcoidosis. I think that clearly organ dysfunction is important, but I think there are other things. First, quality of life is an issue that we often consider in sarcoidosis, and then there are these other symptoms that don't fit nice and neat into a category, like fatigue, generalized malaise, night sweats, whatever it may be. And those are sort of what I think of as soft indications for treatment, not because they don't matter. I don't mean soft in terms of not mattering. I just mean soft in terms of there's no clear-cut objective data in lots of ways to determine whether a patient should be treated. More and more often, we're doing fatigue scores. We're doing, other patient-reported outcomes that help us sort of use this information to decide whether to treat people. But the main approach is really organ dysfunction. And the other interesting thing that I'll point out about sarcoid that you may know that or not know is that for a reason that we don't completely understand, different drugs work differently in different organ systems. And, Plaquenil is, or hydroxychloroquine, whichever one you want to call it, is a prime example. It's a drug that we use in sarcoidosis. It's great for joint involvement, skin involvement. It's great for hypercalcemia, splenomegaly, but it doesn't work very well for the lungs. And why is that? Now, there may be some biochemical explanation. Oh, the bioavailability isn't as good, or it doesn't penetrate this organ, or somebody has a genetic metabolizer of this or that. But the point is, in a large segment of the population, Plaquenil is just not the most effective medication for the lungs. So I think the other approach to treatment is having this experience of knowing which drugs work well for which clinical manifestations of sarcoidosis. And then being able to look at your patient holistically and say, hey, I need to treat these three organs because there's organ dysfunction in these three organs. What's my best drug for treating these three organ systems? And by and large, we want to choose one drug if we can, right, instead of multiple drugs. And we also want to be sure to do no harm. So, if a patient has, hepatotoxicity, we probably want to, hepatic injury, we probably want to avoid methotrexate. If a patient has diabetes, unless we really have to, we want to avoid prednisone. So all of these factors sort of go into the approach to treatment.
Fascinating. So do you start everybody on prednisone as the first go-to, and then sort of add Plaquenil, methotrexate, azathioprine, TNF inhibitors, or do you try some of these other ones up front?
Yeah, so it really depends on the clinical manifestation. So let's say somebody has bilateral hilar adenopathy and they come in with a rash. And, that rash gets biopsied and it's non-necrotizing granulomas, and they have cutaneous sarcoid with lymph node involvement. And, skin disease, there's really, if you talk about skin disease, there's no absolute indication for skin disease, a treatment of skin disease. If you look at the textbooks or you look at the literature, some people will say disfigurement is really the indication for skin disease. But absent that, usually it's a discussion between the doctor and the patient. And there's some patients who have a lot of skin disease and they just say, hey, this isn't bothering me, leave it alone. I don't want to take any medication. And there are others that have little tiny 1 centimeter lesion on their back that nobody can see and they want to be treated. Most are in the middle, and it's a discussion. Point being, if you have skin disease and it's not terrible, then you can start Plaquenil and nothing else. And you can wait for Plaquenil to kick in, because of course it takes at least, starts kicking in around 6 weeks, but takes maximal effect somewhere around 3 months. And you can wait for it to kick in and see if it helps the skin disease. And if it doesn't, then you can escalate to, more potent therapies that have more systemic side effects. On the other hand, if you have somebody who has, an acute arrhythmia or sudden neurologic deficit or a calcium of 11, you can't start some of the other medications we use, like methotrexate, for example, and wait for it to kick in. So in those cases, we have to use prednisone to treat the illness acutely. And then what we do generally in most of those situations, there is some nuance to it, but in most, we would start a steroid sparing agent, whether that be methotrexate, azathioprine, mycophenolate, TNFs. And then, those steroid sparing agents have kicked in, begin to sort of taper off on the prednisone.
Got it. And just some more questions about the musculoskeletal manifestation. So, arthritis. So, do patients with sarcoidosis, do they present with an inflammatory arthritis and swollen joints that are warm and limited range of motion, or do they present with sort of achy joints and the joint exam is sort of fairly benign?
Yeah, so dactylitis, you can have acute swelling of the joints, and that happens in sarcoidosis. And then, of course, Lofgren syndrome, which is an acute form of sarcoidosis, generally characterized by bilateral hilar adenopathy on the chest X-ray and bilateral ankle arthritis, and may or may not be accompanied by erythema nodosum or uveitis, usually uveitis, but not necessarily erythema nodosum. And those patients have sudden sort of swollen joints, particularly in the ankles. And you'll hear stories from patients all the time. All of a sudden, I could not walk. It was so painful that I couldn't get up and walk. But typically, sarcoid doesn't present like some of the other rheumatologic diseases with the, acute swollen red painful joints. It's more of a chronic ache.
Got it. I had a patient that I saw last week with osseous sarcoidosis,
Yeah.
and was sort of thinking about how do you treat that? Is it steroids? Is it methotrexate, hydroxychloroquine? Do you have any insights?
Yeah. So first of all, the thing I would say about osseous sarcoidosis, if you look at the ACCESS study, and the ACCESS study looked at organ involvement in those 700 patients that were the cases for the study, bone disease was something like 0.5% or
Oh,
something
wow.
like that. It's
Hmm.
really thought to be extremely rare. I can tell you from experience that bone disease is not super, super rare. It's I would say I'd put it in the uncommon category, but I wouldn't put it in like the rare category. So the more and more we're scanning people these days, either with CT scans, PET scans, MRIs, we're picking up these bone lesions. And traditionally, they're incidental findings. And most of the time, they're not, there isn't a real indication to treat. We frequently see these lesions in the spine, and we frequently see them in the pelvis, bony pelvis. I don't know the reason for that, but that's just a clinical observation that I can tell you about. And, there isn't a clear cut indication for treatment of these bone lesions either. I sort of use this artificial sort of construct that I've invented in my mind over the years, which sort of has to do with, are the bone lesions increasing in size and number? Are they creating fractures such that there's structural instability of the spine or the pelvis or another bone? Are these lesions located in two bones where they articulate to form a joint, which might, mess up the function of that joint? Things of that nature. And of course, sometimes there's an overlap between osseous sarcoidosis and bone marrow sarcoidosis. And bone marrow sarcoidosis, you're looking for lots of times at the hematologic abnormalities associated with it, so the serology. But bone lesions is more of sort of a something that you follow on MRI or some imaging test. So generally speaking, I would say bone lesions don't need to be treated, but on occasion they do. I've used methotrexate in some people. The response hasn't been great. I think this is another thing that we never really talked about, even though we've been talking for quite a while, is that, what does response to treatment really mean? And, in some patients, when they have acute inflammation and you catch that inflammation early on in its phase and you give them an anti-inflammatory, right, you can reverse some of that inflammation and then in turn restore some of the function that's lost.
Sure.
But at some point, when patients have chronic lesions and the burden of inflammation in those chronic lesions is small, then the prospect for recovery is smaller. And at that point in time, really the goal of therapy really becomes stability.
Mm.
So we don't want things to progress rather than we want to make them better. And there's this false dichotomy when we look at these lesions in sarcoidosis that, they're either inflamed or they're scarred.
Mm.
But the truth is, for most patients, it's somewhere in the middle. And there are patients that have 50% inflammation and 50% scar in whatever lesion they have. And those patients are going to respond a certain way. And then there are people who have 90% scar and 10% inflammation, and they're going to respond in a different way. But you have to be comfortable enough with your patient and observing that particular organ involvement and its response to treatment to say, this is a time where I'm really looking for stability. And this is a time when I'm actually looking for improvement in function. And once you sort of get that in your head, I think it's really, really important to communicate that to the patient. Because if you're not on the same page with the patient in terms of expectations, you could be the best doctor in the entire world and they're still going to be unhappy. Whereas if you lay it out and you say,
Yes.
listen, this has been going on for a long time. I'm going to treat you, but I'm mainly treating you because I don't want it to get worse, not because I expect a lot of improvement. And once you say that to people, then they sort of understand, what you're actually doing, and they don't go home and, expect their lung function to improve by a liter.
Yeah.
So, expectations is a really important thing.
Great. One thing we haven't spoken about so far is what happens to people over time. Is this really a chronic disease that is sort of lifetime? Do some people, does it go away on its own? Does it remit? Is it because of treatment, or does it go away on its own? How do you think about sort of monitoring these people over time and seeing what happens long term?
Yeah. So I think, we were talking a little bit about myths before. And one of the myths I think that's important to point out to, listeners is that people hear sarcoidosis and they automatically think benign disease.
Yeah.
And in some people, it's benign, but in lots of people, it's not. And, a third of patients have chronic disease.
Wow.
And then, if you look at the literature and the natural history of disease, it states that about 2/3 get better. And out of that 2/3, 1/3 get better with treatment, and 1/3, spontaneously remit. But a third of patients have chronic disease. And we can get a sense of chronic disease by looking at a variety of different factors, some of which are the organ manifestations. We know that certain organ manifestations are implicated in chronic disease. So, for example, if patients have lupus pernio, they
Hmm.
tend to have chronic skin disease. If patients have splenomegaly, they tend to have chronic disease. If patients have, at the time of diagnosis, if they have a stage 4 x ray, a scatting stage 4 x ray characterized by scarring, then, within the next 2 to 3 years following, that initial presentation, they have about a 0% chance of that x ray clearing.
Mm.
Now, again, the x ray doesn't necessarily mean that they have activity, but it denotes a pathological process in their lungs. So that's one way to sort of get a sense of your patient and who is going to have chronic disease. But the other thing that's really important to point out is chronicity is not the same as severity. So
Hmm.
just because you have chronic disease doesn't necessarily mean it's going to be bad. So a perfect example of that is, a person who has hypercalcemia, and we know that hypercalcemia tends to be recurrent. It's very
Mm.
pesky, and can't tell you how many times patients have hypercalcemia that turns out to be non-PTH mediated hypercalcemia. They get treated with steroids, or they might not even get treated with steroids. They get treated with a bisphosphonate, and the calcium falls, and the doctors and everybody taking care of the patient is happy. The patient goes home, and then 2 weeks later they come right back in with hypercalcemia and all the manifestations because they've not been given sustained treatment. So many patients, they get sustained treatment. They're on, prednisone initially with Plaquenil, and then the prednisone is tapered, and they remain on Plaquenil, and they're on Plaquenil for 3, 5, 6 years. That's chronic manifestation of disease, but patients do great. They don't have any issues associated with that hypercalcemia. So, chronicity is different than severity, and sometimes those two go together in sarcoid, and sometimes they don't.
Hmm. Um, and so you mentioned, a little bit about sort of research and what the research has found. What questions are being attempted at to be answered sort of in the current sarcoidosis research? What are you and your colleagues working on? And what's the where is the field of sarcoidosis going over the next, 5 to 10 years?
Yeah, I mean, I think obviously the main number one question is, etiology, like what's
Mhm.
causing this disease, and can we pinpoint that and can we eradicate it? And I'm not sure that's possible because there's probably multiple things that cause the disease, multiple exposures. And then, of course, there's a genetic predisposition. I think, the other thing is what I sort of alluded to earlier in our conversation is why are these granulomas sitting in organs and not causing problems in some people, but in other people, they're causing inflammation and causing organ dysfunction. How do those granulomas get turned on and why? There are a number of research questions that are sort of being approached right now. One important question has to do, well, let me back up before I say that. I think, part of understanding sarcoidosis better, I think, emanates a bit from understanding granuloma formation better.
Mm.
And right now, we don't have an animal model to understand granuloma formation, but people are working on in vitro models to simulate granuloma formation, and these are proving fairly fruitful in understanding some of the mechanisms that underlie granuloma formation. I expect, in the future, these models are only going to get better, and there may be more of them. And that's going to help us understand the mechanisms involved, therapeutic targets in that granulomatous formative process to intervene. So I think that will be helpful. I think, one of the other things that we've learned is, there's this process called autophagy, which has to do with sort of cells that sort of fall into disrepair. They sort of need to be cleared from our system. And there's some literature that suggests that, autophagy is sort of dysregulated in sarcoidosis, and that might be culpable in not clearing some of the antigens that may persist and may actually cause, the immune system to sort of be revved up and go into overdrive as it does in sarcoidosis. So I think understanding those mechanisms a little bit more will be helpful. There are a bunch of others, but I think those are two that I would sort of highlight off the top of the bat.
Fantastic. And what resources are out there for patients that have sarcoidosis or their families? Where can physicians refer these patients for support?
Yeah, so I would say one of the better organizations and websites for information about sarcoidosis is from the Foundation for Sarcoidosis Research. They have a plethora of information on their website that talks about diagnosis, treatment, speaking with your doctor. You can register and become part of clinical trials and research. But the nice thing that they have is they have a list of doctors in various areas. And
Sarcoidologists, you mean?
yeah, sarcoidologists. I mean, some of them are not necessarily true sarcoidologists. Some of them are like if you have a pulmonary problem and you live in so and you have pulmonary sarcoidosis, you can go to X.
Got it.
But some of them are true sarcoidologists. And the other thing is that FSR, Foundation for Sarcoidosis Research, has really gone out of their way to sort of sponsor these sort of, I don't want to call them clinical centers of excellence, but something akin to that. So there are centers throughout the United States that really specialize in doing sarcoidosis. And not only do they tend to have sarcoidologists, but they have the supporting staff and subspecialties to deal with complex sarcoidosis. And the website points those places out as well. The FSR does have a support group. We at Sinai have a support group. We've had a support group since the 1980s,
Wow.
and we meet either once a month or every other month and talk about various topics important to sarcoidosis patients. I've actually found the support group to be really rewarding as a physician because it sort of allows me to talk to patients outside of the office. In the office, there's a very regimented setting and you've got a specific job to do. You've got a limited amount of time and you're talking to this patient very like clinically. There's a construct. But when you're talking to patients outside of the office and you're just talking to them about their sarcoidosis, you get insight that you wouldn't otherwise get if you're in the office, and you hear them in a different way. They hear you in a different way. And I think it's really been beneficial to my growth as a physician, but also a sarcoidologist, of course, over the years.
Fascinating. I couldn't imagine a better place to end. Adam, this has been really enlightening. I'm certainly going to take many of the points that you made back to the clinic, back to my patients, and hopefully try to improve their clinical care. This has been wonderful. Thank you so much for your time.
Yeah, well, thanks for having me. It's been really fun to share a passion of mine with people willing to listen.
Great. Have a good day.
Okay, you too.
Hopefully, this episode has provided you with a deeper understanding of sarcoidosis and the impact that it has on the lives of those affected. The discussion has certainly improved my understanding of this complex disease, including very valuable insights into its diagnosis and management. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, as well as on Apple Podcast, Google Podcast, Spotify, and on your favorite podcast app. Until next time, let's all work together to get rid of those pesky granulomas. And of course, stay healthy.